Howdy, and welcome back to the podcast. Thank you for joining us yet again. We have a episode today all about pelvic floor stuff from a pelvic floor physical therapist or a physical therapist that specializes in pelvic floor. Yeah. So, hello. Thank you, Tina, for being here today.
Of course. I'm actually an occupational therapist. I just have to say.
Oh, okay. My bad. Oops. Sorry.
Okay. That's
so
okay.
occupational therapy versus. So what is occupational therapy versus physical therapy for those that don't know?
Okay. So good question. And a lot of people don't know what occupational therapy is. So I'm glad you asked. So in the realm of just therapy in general, there's PT and then OT. And then there's also speech therapy, right? Those are the three different types of rehab typically. And every setting is going to be a little bit different. So let's just talk about the realm of pelvic floor because that's what we're here for. So in the realm of like pelvic floor, I would say we PTs and OTs essentially we do the same things almost. It's just the lens that we use that's different. So it's kind of like when you think about physicians, MDs and DOs, they're both physicians, right? But the lens that they use to prescribe certain things is going to be a little bit different. So say you went to a physician, you had to get referred to a cardiologist. That cardiologist could be an MD or a DO. They might prescribe the same things, but it's just a different schooling that they went through. But at the end of the day, they're still both MDs, not MDs. They're both physicians. So with pelvic floor, it's kind of the same thing. So OTs, we tend to have a little bit more of a holistic lens, I would say. But that's not to say PTs can't be holistic and OTs can't be more biomechanical. We can still have those different, like those similarities, but in the realm of pelvic floor, we can do the same things. It's just different lens.
So I have a client that comes in. What is your lens, the initial like screening questions versus what a PT's lens might be?
Okay. So from a PT lens, it might be a little bit more biomechanical, right? So like they might be assessing, like their goals are going to be set up to look at overall strength, endurance, and maybe like coordination of the pelvic floor. OTs do that too, but we focus on ADLs. And so ADLs are activities of daily living. So two ADLs are toileting and sex. The two primary functions of the pelvic floor are toileting and sex. So that's the lens that OTs use, is like what is impairing your toileting and sexual function, whereas a PT's lens is going to be a little bit different. Again, I say that with like an asterisk because like that's not to say that OTs can't also assess strength, endurance, and coordination and a lot of other things that is typically more PT focused, and that also doesn't mean that PTs can't also look at the lens of like ADLs and toileting and sexual function, because at the end of the day, like I said, the pelvic floor's functions are pee, poop, and sex, and those are ADLs. So PTs can still kind of like go that route if they want to, and I can also go that route if I want to. There's a little bit of gray area, but generally speaking, that's kind of like the difference. So the lens is more ADL focused, I would say, with OT.
So if I have a physician prescribes me, I'm having issues with sexual health or incontinence, then that physical therapist or that MD or the referring individual might lean more towards the OT initially versus I'm having like performance issues, like I can't brace correctly, or is it, and that person would get referred to a PT?
So typically it's just pelvic floor therapy, and then it could be either a PT or an OT. Does that make sense?
Yeah,
so that's why I made that cardiologist reference, because it could be a cardiologist, but like, I mean, you're getting referred to a cardiologist, but it doesn't matter whether it's MD or DO, right? Like so it could be either or.
How fun.
Yeah.
Good analogy.
Because like I still work with clients that are like dealing with incontinence when they're running, dealing with incontinence when they're lifting weights and stuff like that. Because at the end of the day, movement is an occupation. So that's also, I know I mentioned ADLs, but that's another thing that OTs work on too, is making people more independent with their overall occupations. So, and anything's an occupation. Lifting's an occupation, running is an occupation. Moving in general is an occupation. So again, that's where like the lens is just different. But if you're getting a referral, it could be either or, PT or OT.
In my head, for whatever reason, I always thought OT was more refined motor patterns or motor skills versus PT was like more large or big,
like gross motor.
Yeah, gross motor problems. Is that accurate or not so much?
Not so much. I can see why you think that though, because like in the school system, PTs, I would say, again, I don't have like a whole ton of experience with school system, but this is just from what I know. PTs tend to work on more of like the gross motor stuff with peds like kids in schools, and then like the OTs are the ones doing like the handwriting, the fine motor type stuff. So I could see why some people think that, but that's not necessarily true. I could see how that's true in the school setting, maybe the pediatric setting, but pelvic floor wise, that's not true. Yeah, because
nice.
I mean, pelvic floor is not fine motor.
Yeah, fair. So what is the pelvic floor for people that don't know?
Yeah.
Right, let's get into it.
Great question. Okay, just side note, real quick. I just want to say, like, because like nobody really knows what the pelvic floor is, and then on top of that, I'm an occupational therapist, so most people don't also know what that is. So when I tell people I'm a pelvic floor OT or I'm just pelvic floor, like they're just like, oh, what do you do? I just feel like I'm a double-horned like unicorn, like nobody knows what I do. So anyways, to break it down of like just what the pelvic floor is, it's a set of muscles. The pelvic floor is a set of muscles that sit at the bottom of your pelvis. So essentially, they hold all your organs up, like your bladder, your uterus, and your rectum. For men, obviously, you don't have a uterus, so just your bladder and your rectum. And their functions are, like I mentioned earlier, pee, poop, and sex. That's like the simplest way to explain it.
So it's related to pee and poop, how, and then sex, how.
Mm-hmm. So with your pee, so your pelvic floor needs to have a few different things that it needs to be good at. Those three things are strength, endurance, and coordination, right? So you need good strength to hold in your pee and poop so you don't pee or poop yourself when you are like walking or just doing your daily activities, right? You need endurance so that you can hold it while you're like walking over to the bathroom. That's endurance. And you need coordination so that you can hold your pee and poop in when you're sneezing, jumping, running, lifting, all that kind of stuff. So you need all three. So that's where the pee and poop portions kind of tie in. And then obviously like your pelvic floor is also holding up your uterus. So everything that your vaginal opening is responsible for also plays a role with like your pelvic floor. So if those muscles are not working effectively, it can look like pain with sex. Like if those muscles are really tight, when you're engaging in intercourse or you're intimate with your partner, your pelvic floor muscles also contract and lengthen involuntarily. And so those muscles need to be able to do that effectively. If that coordination is off, people can also deal with pain with sex.
What does the pain look like? What is the symptom of pain? Like, is it immediate insertion? Is it the entire thing? Like the entire process? Like, where does the pain exist? How does somebody know that they're having a problem with pelvic floor during sex?
Right. Good question. So it varies for everyone. I would say most people have, when they're dealing with pain with sex, it's usually at the outermost portion of the pelvic floor. So there's 3 different layers to the pelvic floor. So it's usually like the one that's closest to the vaginal opening that people tend to have the most pain in, but that's not all the time. Sometimes people have pain with deep penetration. So say they're intimate with their partner, they're complaining of pain once it's in and like once they're engaging in intimacy, right? Some people have pain just at entrance. Like the second something even goes in, it's like painful. Wow. So it just varies for people. Sometimes it's at the front of the vaginal opening. Sometimes it's deeper. So yeah.
And
it
then,
just depends.
So I have so many more questions.
Yeah,
so
okay.
because we're on this topic. So let's say I am having pain. What can I do at home to even test, like, is this related to my pelvic floor, or maybe do I have to go look at something else, right? I have to go, maybe it's like it's a cyst or something else. Like, at what point do I know what the problem is?
It's like the pelvic floor versus something else. Yeah, good question. So typically when people are dealing with pain with sex and it's a pelvic floor thing, usually those muscles are just like really tight typically. So they're either really tight, or it could also be something called vaginismus, which is when your pelvic floor muscles are involuntarily like contracting when they don't need to be. So that is like tensing up your muscles. And so any time you put something inside, it's going to be painful. And that goes apart from intimacy too, like even tampon insertions, OBGYN visits, like just getting a regular checkup, like can be really painful. So any form of insertion, right, can be painful. So generally speaking, like I said, it could be just a musculature thing. One way to kind of check to see if it's a muscle thing, a pelvic floor thing, is it just kind of like sitting on a ball almost, like, so that you can kind of feel what your pelvic floor muscles are doing. And your pelvic floor muscles, they coordinate with your breath. So anytime you take an inhale, your pelvic floor naturally lengthens and drops. And then when you exhale, it naturally comes back up. So something you can do is sit on a ball, like on the floor, and then kind of like put one hand on your chest, one hand on your rib cage, and then inhale. your diaphragm should come down. And if you're sitting on a ball, you should be able to feel your pelvic floor kind of come down. And then when you exhale, you should also feel it come back up. And I say hand on the rib cage because when you inhale, your ribs should expand this way. And when you exhale, it should come back together. So if all of that feels okay, like you feel your pelvic floor drop, your ribs are expanding laterally, you feel that on the inhale, and then you exhale and everything comes back in and there's no like tension or anything like that with that, I would say maybe it's not a muscle thing, but I also think it's good to get checked by a pelvic floor therapist because then I can do an internal exam, kind of see what's going on. I can look at the tissue, look at your vulva, and then do an internal exam and assess your musculature. If everything looks fine there, like say like, okay, I do my initial assessment, strength, endurance, coordination is all fine. You're able to fully lengthen your pelvic floor and then also contract it, and it's none of that, then it's very likely it could be like a medical issue, like a cyst. It could be endometriosis or something else, you know? So that's when you would probably need further imaging and maybe a follow-up with the doctor versus a pelvic floor therapist.
So a ball, because I'm picturing this inside my head, and if somebody's listening to this or watching, then like a stability ball.
Kind of like one of those like Pilates like balls. So not like a basketball. One. You don't want like you don't want a hard surface. Yeah. I want like like a small like soft ball because I want once you're sitting on the ball, like you should be able to feel your pelvic floor like kind of drop, and then I want the recoil basically from the ball. Does that make sense?
Yeah.
Because if it's too hard, you can't really feel your pelvic floor.
It's pushing in aggressively.
Exactly. And then it could just be worsening the pain too if you're sitting on a hard ball. So a nice soft like Pilates type ball, exercise ball, whatever you want to call it. I think that would be the most beneficial. Yeah.
Cool. And so when I go see a pelvic floor OT. Mm-hmm. You said you did a full internal examination. Yeah. What exams do you do?
So when I do an internal exam, typically what that looks like is I ask a client to undress from the waist down. I step outside and then come back in. So kind of think of like what an OB visit would look like if they're looking like it, or if they're looking at doing like a checkup. Like, say you gave birth and they're looking at your tissue or anything, or even when you're pregnant, they look at your vulva and everything just to see how everything looks right during your pregnancy. So that's essentially what. Kind of similar like concept is kind of like what I do. So I'd have them undress from the waist down. I step outside, come back in, and then I get a glove, lube my fingers up and everything, and then I insert my fingers into the vaginal opening, and then I kind of palpate the muscles to see what's going on, if I notice any pain, tension, anything like that. And then I ask them to do a series of things like a Kegel, and then I test endurance, so that would be like holding for like 10 seconds, holding it 10 in a row if you could do that. And then there's something called quick flicks, where is it like, can you contract and then let go really quickly? So contract, let go, contract, let go. That kind of tests like overall coordination. So I do things like that to check to see like what the muscles are doing, how they respond. And then I also see if the pelvic floor is able to, like if they're able to bear down, meaning like pushing like you're pooping almost, or pushing like you're pushing a tampon out, or pushing like you're pushing a baby out. Are you able to then lengthen your pelvic floor and push against it, and then also be able to have it come back in? So a lot of different things that I would look for to assess for like a healthy functioning pelvic floor.
So that's crazy cool and wild. So we have these 3 different layers of the pelvic floor. Mm-hmm. Whenever you're inserted into the vaginal opening, you have what portion of the 3 layers are you feeling? Like
all of them.
All of them?
Yeah.
How? How can you feel all of them? That's crazy.
First of all, I have long fingers. It's funny because when I was a kid, everyone used to tell me like, "Oh, you have such long fingers. Like, you're going to be a musician." And I'm like, look at me now. Nope, I'm a pelvic floor therapist.
That's fun.
So yeah, like it seems crazy. Like, oh, how are you getting all the way down to like a 3rd layer of a pelvic floor? But you can. Yeah.
Wow.
So it's more so like how you're moving, I would say. Sometimes it can get pretty hard to get to the 3rd layer just because it is really deep in there. If it's really hard for me to like get into the 3rd layer and I'm unable to do so, and it's something where the patient really wants me to check for, then I would go in rectally. Because your pelvic floor muscles all attach at the tailbone. So sometimes the best way to get there to the 3rd layer is going in rectally versus vaginally.
Damn.
But most of the time I don't need to do that. I can get in through the vaginal opening.
That's insane.
Yeah.
I didn't realize that you guys were so personal.
Yeah.
Like, I think PTs typically, I don't know that this is, I mean, maybe a pelvic floor PT does this. Yes. I also realize that it is extra training outside of just regular PT school. So I get that. But I thought everything was like outside of the body.
Like external. Right?
External.
Yeah.
But I guess it makes sense to that I can feel my bicep from here.
Yes.
I can't really feel my pelvic floor from my stomach very well.
Exactly. So you kind of, in order to like fully assess what the pelvic floor is doing, you do kind of have to go internally, but it's not necessary. It's not required. Like if somebody's really uncomfortable with it, we don't have to do it. There are so many other ways I can assess the pelvic floor externally, like the ball thing that I went over. So that ball example is a good way of like seeing what the pelvic floor is doing without me doing any sort of like internal work. So that's still an option. I think sometimes people think like, oh, I need to do an internal assessment. No, like if you really don't want to, we don't have to. Like there are so many ways we can still get you the help you need without doing an internal assessment.
What are some other external assessments you can do?
Yeah. So on top of...
Like how do you test for endurance externally?
Yeah. That's a really good question. So obviously it wouldn't be the same as me like putting my finger in and then like assessing if they can hold it for 10 seconds. Something I would have just them do is sitting on like a rolled up towel and them telling me what they're feeling. So if they feel like, okay, like I'm losing it, typically you can. Like if you're holding it and you're like, I think I lost it at 4 seconds. I just use like whatever the feedback that they're giving me verbally as their assessment.
It's a little limiting, unfortunately, because if there isn't the proprioception already, then that makes it really challenging to like, when did you lose it?
Right.
You know, so that can be.
It can be challenging, but I do have to say people still make improvement with that. Because I also tell people, like, you know your body best. Yeah. You know your body better than I do because you've been living with it for however many years, right? So even though, yes, it's not like a formal assessment, if that's what they're feeling, like that's kind of what I'll go with. Because I also do virtual assessments. And so obviously I can't do internal stuff, right, with the virtual assessment. So I do have to get really creative with how I'm going to assess their pelvic floor. So in addition to that, though, your pelvic floor works in coordination with your diaphragm. So another thing I can do, too, is more like ribcage stuff. Because if your ribcage and your diaphragm are working pretty well, chances are your pelvic floor is also, like, responding the same way. Nice. Another kind of approach is just, like, symptom, like, reporting. So if they are noticing leaking when they're running, I'll go over like a few things and, you know, like, okay, like if you're noticing like heaviness during this movement, okay, let's scale it back, let's do something else. So that's another way of kind of like testing for what the pelvic floor, how it's responding to certain movements too. That's
good. Yeah. So a couple weeks ago we had Priya on and we were talking about pregnancy and some changes that are happening within the body. Yeah. What changes with the pelvic floor, either during pregnancy, the first, second, third trimester, and maybe even after pregnancy?
Yeah, really great question. So when I work with clients that are pregnant, the three things that I usually tell them that the three major changes that happen to our bodies typically when we're pregnant are our rib cage flares. So like if you want to like touch your own rib cage right here. So normal is about 70 to 90 degrees. When we're pregnant, in order to make room for baby, that angle goes up to like 135 degrees. So it widens substantially, right?
Wow, that's a lot.
Yeah, it's a lot. And so, again, it's just normal physiology. Like, one thing I really hate is when people start using, like, really fear-mongering language. Like, your rib cage, like, sprays open and, like, your back is, like, you know, this and that. Like, your diaphragm moves up, like, about 4 inches, too. And, again, like, people will make it seem like it's this horrible, like, scary thing. And it's, like, it's just normal physiology. Like, this is just things.
What happens?
It's just what happens to our bodies. It's not horrible. Like, it's a beautiful thing that happens to our bodies. Like, our bodies are so resilient, you know? So that's one thing. Rib cage flares open. Diaphragm moves up about, like, a few inches. Another thing I like to tell, or that I go over with clients, is your pelvis also tilts anteriorly. So if you think of your pelvis as a bowl of soup, that bowl of soup is basically tilting forward. Again, just another normal thing that happens during pregnancy to accommodate for the growing fetus, right? On top of that, our rectus abdominis, or our six-pack muscle group, stretches apart. So sometimes people, again, will use fear-mongering language, like your abs just split open, you know? And it's like, it's not stretching open, like it's stretching apart. apart, but it's gonna come back, like it's okay.
Yeah.
So your abdomen like stretches apart, obviously, again, to like make room for growing baby. So those are the three major changes that happen. And so because your rib cage and your diaphragm work so closely with your pelvic floor, it also affects your pelvic floor. And then also like, so your pelvic floor, it's also like I said, one of its responsibilities is to hold all your pelvic organs up. So now that you're pregnant and you have this growing fetus, it's also like it's carrying extra load as pregnancy continues, right? So now it's like holding up all your organs, and now it's also holding and baby. Yeah, and so that's why like towards the end of like during the third trimester, a lot of women will complain about feeling like heaviness sometimes. And it makes sense because your pelvic floor is just it's adapting to a lot more load. And this is going to be a little bit of a segue, but this is why strength training throughout pregnancy is so important, because if you're not strength training, how is your pelvic floor supposed to respond to the load, right? Like I'm a big advocate of prehab too, like preventative rehab to decrease your risk of overall pelvic floor dysfunction when you're postpartum. Doing the proper work during pregnancy and even before pregnancy is going to help you so much. Like if your pelvic floor understands how to squat with heavy weight, it's going to adapt much better throughout pregnancy.
So what's the carryover from a heavy squat to holding a baby? Mm-hmm. How does somebody make that real? Like, oh, I understand why I'm doing a back squat to help my pelvic floor. Okay. Does that make sense?
Yeah. So sometimes people will ask me like, oh, what are like the best exercises for pelvic floor, just pelvic floor in general? And I say like, there's no one like great exercise. Like all of it is good. Like squatting is just good overall, like apart from all the benefits of just exercise in general. But in like, since we're talking about pelvic floor specifically, it just strengthens your pelvic floor. Like that's like as simple as I can put it. It is able to respond to load. It's handling like the endurance that you have to like deal with when you are squatting, and the whole coordination thing as well. So if you're squatting, sorry, let me backtrack a little bit. So I talked about how your pelvic floor works together with your like rib cage and your diaphragm, right? So anytime you take an inhale, your diaphragm lowers, your pelvic floor also lowers, right? So when you're doing something like a squat, think about like the breath pattern that you're using when you're squatting. So typically, like what I like to do is I inhale on the way down and then exhale on the way up. So just simply doing that is already working on the coordination of the pelvic floor and the strength and endurance on top of it, right? So you're tackling all three things just with one movement. Yeah.
I like squatting.
Yeah, squats are great.
Whenever I coach squats, for a long time now, since powerlifting, it was always a conscious decision to have a Valsalva at the top of, like, to engage in a big diaphragmatic breath at the very top of the movement. And then after doing that, after breathing, then I Kegel to help give some extra support, and then I complete my squat. Just because I'm squatting under like 700 pounds, like it matters at that point, especially like making sure that all these little things are appropriate. So whenever, I don't know how you feel, if you would correct me if differently, but what I coach is that kind of same thing now. It's we have a Valsalva maneuver, and then we Kegel, and then we squat. And at the very top, as we come up, we're releasing our breath, and then again I reset at the very top. Is that an appropriate use of the pelvic floor or cueing?
I don't like the Kegeling thing.
Okay, why?
Yeah. So your pelvic floor is already doing its thing when you squat. Does that make sense? So then Kegeling like through the movement or on the way up, it increases your risk of like tension and tightness in the pelvic floor. So I would say just let it do its thing. So it's kind of like a good comparison I would compare that to is like when you're doing a hip thrust, like are you going to be overly clenching your glutes at the top? No, you don't want to do that because it's going to increase tightness. If you're increasing tightness, you're decreasing the ability for that muscle to be able to fully lengthen when it needs to, right? So using the hip thrust example, that's going to increase your risk of hemorrhoids, difficulty with defecating, having bowel movements and stuff like that. So I'm not a fan of like Kegeling through movements because your pelvic floor should already be responding to like the way it's supposed to when you're doing the movement. But I do have to say, like, there's nuance to everything, right? Like you're also squatting like 700 pounds. So if you feel like you need the extra support, I would say, okay, like if you feel like that's good for you, then you can go ahead and do it. Especially if you're not having any sort of like symptoms, like you're not having problems like having bowel movements, you're not dealing with tightness and stuff like that. So yeah.
But maybe not for everybody.
Yeah.
And maybe general population is probably a no.
Yeah, general population, I would say no. You don't need to Kegel through any sort of movement. Yeah.
Should I ever be Kegling?
No.
Like to practice?
No.
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 Hot take.
So that's a huge misconception. Like, even like today, so I posted like a reel because I'm on social media. So like I posted a reel. It was like a funny reel that I posted of like, oh, like, hi, I'm Patty, the pelvic floor. And I like did this silly educational video about what the pelvic floor is. And people were commenting like, oh, this is a good reminder for me to do my Kegels. And I'm like, oh, like, no, I don't want you to be doing your Kegels. Like, I'm glad you found it educational and silly and funny. And like, I'm glad like I'm educating people about the pelvic floor in general. But like, my goal is not to like tell people to do Kegels. So let me tell you why. So if you think about like your bicep, right? When you Kegel, so typically when people are dealing with incontinence, I'm going to use the example of incontinence because most people that are trying to seek out pelvic floor therapy are dealing with incontinence, meaning they're peeing their pants when they're doing certain things. Most of the time, I'd say 95% of the time, people that are dealing with incontinence with movement have a really tight hypertonic pelvic floor. So I'm going to use my bicep as an example. So if this is how
what does hypertonic mean?
Means high tone, so like tightness, inability to like fully relax and lengthen. So if you're dealing with incontinence, say my bicep is my pelvic floor, and this is as far as you can go. And now people think like, okay, well, I need to do my Kegel. So now they're doing Kegel after Kegel after Kegel after Kegel. You're not solving the issue. You're just making the muscle a lot tighter. And tight muscles are almost always weak muscles. So you're not solving the issue here, right? So what you want to be able to do is fully relax and lengthen the muscle, and then from there be able to contract, right? So when you're doing a bicep curl, you're not going right here and just doing curl, 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 right? Like the goal is to like fully relax, lengthen, and then you want to go through the full range of motion. So the same thing goes with the pelvic floor. You want to be able to fully relax, lengthen the pelvic floor, and then from there, then contract. But also at the same time, you don't want to be isometrically doing that with your pelvic floor because your pelvic floor works so closely with your transverse abdominis, which is your deep core, your diaphragm, and other muscles too. So just doing an isometric contraction of your pelvic floor is not addressing the whole like picture. So again, using the bicep comparison, like if I was just squeezing my bicep, like that's not really going to gain strength, right? Like being able to fully relax, lengthen, and then hold a weight and then be able to curl it back up, that's what's going to gain strength. Does that make sense?
Yeah.
Yeah.
It does.
So yeah, Kegeling is not the answer. For most of the time, it's not the answer.
So what is the answer? I mean, is it weight training?
So weight training with proper breath work, I would say. So say somebody's coming to me and they are dealing with incontinence with squatting. So I would say like we need to scale it back a little bit. So like drop the weight a little bit, see how your breath, what you're doing with your breath through the movement. If you're not having any sort of symptoms with that, let's focus on the breath work with the squat at that weight and then progress your way up. If I do my internal assessment and it's just like a lot of tone, inability to fully relax and lengthen, again, I would say like scale it back. We really need to focus on like lengthening the pelvic floor. So I would probably recommend some stretches, some deep breathing with the stretching, mobility work, all that kind of stuff to help lengthen first. And then from there, then we can like contract and then load it with the movement. Yeah.
I'm sitting here thinking about how I can like lengthen my pelvic floor while sitting here.
So
I'm like pushing out and I'm like, does that make sense? And then Kegeling in, like, is that enough or not? Like, that's not appropriate.
So I would say like tie it in with your inhale. So if you're sitting here and you want to like lengthen your pelvic floor, I would say inhale, like imagine your pelvic floor is like in an elevator. So at rest, it's at level 0, let's call it 0. So when you inhale and you're trying to lengthen it, let's go down to like -3. So like the 3rd floor of the basement, right? And then when you're contracting, try to bring it all the way back up to +3. Does that make sense? So that's just if you're sitting. Another good way to kind of like focus on relaxing the pelvic floor is doing a happy baby. So that's, that yoga pose where you're laying on your back, you're holding up your legs. That just kind of like stretches your pelvic floor a little bit better. And when you do that deep inhale, you're getting a much better like relaxation and lengthening of the pelvic floor that way. So a few different like positional changes can help relax the pelvic floor a lot better.
How cool.
Yeah.
How interesting. Is it normal to have incontinence when lifting weights, for example?
No. So it's very common, but it's not normal. And I think that's another really big misconception too, especially with the pregnant postpartum population. A lot of moms are told like, oh, well, that's just part of having a baby. Oh, well, like you're 6 weeks after birth, like it's normal to be leaking your pants after, this far out after baby. And it's just not true. Like help exists. Help is out there. Pelvic floor therapy exists for a reason. So I would say like 90 to 95% of the time it's a pelvic floor issue when it comes to incontinence. There is a small percentage chance that it could be like a sphincter problem, like a urinary sphincter issue. So that could also be, one of the reasons why. But again, like 95% of the time, I would say it's a pelvic floor issue and it could be fixed.
So I used to compete in powerlifting.
Yeah.
And it was almost like not a rite of passage, but it's like a point of pride for some women that would deadlift and then they would like pee on
their pants. Yeah.
And I mean, it's not just like a little bit of pee.
Yeah.
I mean, we're talking like full waterfalls on the platform in the middle of competitions. And it was like, yeah, this is cool. Like I lifted so heavy and I was like, I don't know that this is healthy.
This is not good.
Yeah, this isn't a good thing.
I feel like that like whole concept, like it just ties into women's like dealing with certain things, women's pain, like it being like a badge of honor almost. And it shouldn't be. Like we shouldn't be prideful that our pelvic floor is not working well or that we're dealing with like say pain with intimacy or something like that. Like that's not something to be proud of, right? Yeah. Like it means like it's a signal that something's wrong with your body, and not that your body's broken. It's just there are changes that have happened and it's rehabable. Like I don't think rehabable is a word, but I'm making it a word. Yeah.
Yeah, it is today. I like it. It's a good word. Yeah, jumping seems to be another very common thing where it's just like, oh, I can't. I have a couple clients that I can't do jump rope, and I'm kind of not willing to because I'm going to pee, even if it's just a little bit. And so, what does that client? Is it typically the hypertonality that you were talking about? Is usually what it is.
Typically that, but also it could also be like a hypertonicity and like coordination issue as well. Especially after birth, because our pelvic floor stretches 2 to 3 times its normal size during childbirth. Wow. So you can imagine, like, if your bicep or your quad stretched 2 to 3 times its normal size, anybody would be like, you need rehab, right?
Yeah.
But then for whatever reason, when it's your pelvic floor, it's just like, oh, that's normal. Like, oh, like your pelvic floor literally tore during childbirth. You were stitched back together and there's no rehab afterwards. Like, why is it not normal for people to get rehab afterwards, So when it comes to like the jumping thing, it could be a hypertonicity thing. If it's after birth, I would say like it's very likely it's a strength, endurance, and coordination thing. Also, something people don't often realize is during high impact activity, your pelvic floor actually absorbs 2 to 3 times your body weight. So imagine like that much load going through your pelvic floor, and your pelvic floor has already gone through so many changes during pregnancy and then postpartum. So it takes not just time, because I think like when I say, oh, it takes time for it to come back, people think it automatically comes back. It doesn't automatically come back sometimes. You need to progress your way back into jumping activity. So that's why like when I'm with my postpartum clients and jumping or running is one of their goals, I progress them through a series of exercises that's going to help your pelvic floor be able to understand that much load through it again. Like so I would start off with something like just like heel slams, like getting on your tippy toes and doing like a calf raise and slamming your heels onto the floor. That's a really good way to just start getting your pelvic floor used to the amount of impact and load going through it. Yeah, exactly. So yeah, I think so often women are told that like, or we're fed this like lie that it needs to be like a badge of honor. Like, oh, I peed my pants. It's like, no, like that shouldn't be something you're proud of.
Well, it's because I had kids. And it's just like, well, it doesn't matter.
Right. And like people will also say, like I was talking to a friend of mine that I was talking to a few years ago, and she's like, oh, I didn't even know pelvic floor therapy was a thing. Like my friends, like they just say, oh, like I just put on a pad and like this and that. But I'm like, you know how much money you're spending on pads? Like what is that supposed to be a long-term solution for lifelong? Like if you don't address it now, like chances are when you hit perimenopause and menopause, it's just going to get worse. And then you're going to be the old lady in the nursing facility that's peeing her pants all the time when it could have been addressed ahead of time,
How does perimenopause affect or menopause affect the pelvic floor? Just weakness?
A lot of different things. So when perimenopause and menopause happens, we lose our estrogen, right? And so for females, estrogen is really important because it plays a big role in bone density, muscle mass. So once we hit menopause, it's basically gone. Our estrogen level is actually lower than it is of a man's. So it's really, really low.
It's the only time in life that I think testosterone is the highest in women.
Wait, what?
The ratio of women of testosterone to estrogen is the highest during that time. Testosterone being higher than estrogen.
Wait, sorry, repeat that.
Testosterone during that time, testosterone is higher than estrogen. And that's the only time in a woman's life.
Basically,
it's crazy.
But testosterone can also decrease. And so like we can also talk about hormone replacement therapy for women in menopause and all that too. That also plays a benefit. So going back to like the changes with like the pelvic floor, so one of the things that happens is like your vaginal opening or your vaginal walls kind of lose elasticity and like suppleness. On top of that, like your ligaments aren't as supple and as they're not as supple as they used to be because we don't have like the estrogen anymore. So, and then on top of that too, like once we hit like menopause, your urethral sphincter loses 2% of its like strength and elasticity every year. So that's also a pelvic floor issue. Like you can address that with proper exercises during that whole season. And then like this is kind of like an off track too, but when we're after childbirth, we also are postpartum and we also have really low levels of estrogen. And it's because our prolactin is so high because we need to make milk. Like if you're pumping and breastfeeding, I have to say, if you're using formula, might not apply to postpartum women, but if you're breastfeeding, you're pumping, prolactin's really high. In order for prolactin to stay really high, estrogen is really low. So that's, we're essentially almost like menopausal too. We're going through like similar changes as a menopausal woman than we are after birth. Yeah.
Wow. Yeah. I didn't know that.
Yeah.
I didn't know a lot of that. 2%?
Every year.
Every year?
Yeah. So that's why it's common for menopausal women to also be dealing with incontinence during certain things. I know, isn't that wild?
That's madness.
Yeah.
So most of your population that you work with, are they typically menopausal women?
No. So I would say most of the time, most of my clientele is pregnant postpartum women, but I also work with perimenopausal, menopausal women as well. Because again, like a lot of the changes that happen with menopause are very similar to postpartum as well. Yeah. Maybe not the same like anatomical changes that, like with your ribcage and all that have happened during pregnancy, but hormonally a lot of changes have happened. And as a result, your pelvic floor is also going through similar changes, I would say. Yeah.
So pelvic floor lengthens 2 to 3 times during pregnancy. Ribcage grows or flares like 50%. It's like ridiculous amount.
Yeah.
And then the other change that happened was the diaphragm drops, right? 4 inches.
It goes up.
Diaphragm rises
during
4
pregnancy.
inches. Okay.
Yeah. And then our abs also separate.
Split.
Yeah.
So how much of these things come back to normal and how fast? Like, does my ribcage stay flared forever?
It depends. Like, so normally, like it should just come back to the normal 70 to 90 degrees, right? Sometimes it does stay flared open, and like you need a little bit of guidance and proper breath work and exercise to kind of bring it back down. Yeah, so sometimes it'll just come back on its own. Sometimes it doesn't. But yeah, it's definitely something that we can like fix. We can bring it back together through certain exercises.
So running is very breath heavy. There's not a lot of load. But does that also is that more of an endurance for the pelvic floor and coordination for the pelvic floor rather than more of a strength thing?
I would say a little bit of everything, like a little bit of all of it. So because I mentioned your pelvic floor absorbs like 2 to 3 times your body weight, right? So anytime you heel strike, anytime your heel hits the floor, that your pelvic floor is absorbing 2 to 3 times your body weight, right? So we need to be able to allow our pelvic floor to understand what that load looks like. So progressing back into running is so important, right? And because our breath is so deeply tied to our pelvic floor, if a woman's dealing with incontinence with running, I would look at the strength, endurance, coordination piece, but I would also look at the breath work piece. Because sometimes people are like, okay, well, like, I don't know how to breathe when I'm running. So sometimes, like what I usually tell clients is try to find a breath pattern that works for you. So something I usually tell people is like a tends to work really well because it decreases the amount of like load going through the pelvic floor like all at once. So if you're like holding your breath and running and then you're like exhaling all at once, it could increase your symptoms. So using a proper breath pattern that just works best for you could be really beneficial.
I like that breath pattern a lot.
Thanks.
I've never seen that. That is so cool.
Yeah.
Because I would imagine what you're doing is like decreasing the amount of load in that in between, right?
Yes,
That's why you're breaking up the two in, two out.
Exactly.
Like that is so ingenious. That's really well done.
Yeah. That on top of like just leaning forward a little bit. So if you're standing straight up, that's when that number is a little bit higher, like the 2 to 3 times your body weight through your pelvic floor. It could even go up to 6. It's like sometimes it's even 4 to 6 times if you're standing straight up. But simply leaning forward, that number goes down to like anywhere from 1 to 3. So simply like just those 2 little changes of leaning forward and then using the different breath pattern, that could also like help a lot with your pelvic floor.
Oh, cool.
Yeah.
Let's say I'm having trouble with that jumping, and we have the heel drop or the heel strike.
Yeah.
Is the next progression better rather than jumping up onto a small maybe box or a plate or whatever, stepping like a depth drop? Is that something that's appropriate? Just like falling off of a high position or even a moderately high position, a box, and holding, because that's a lot of downward force.
That's a lot of downward force. Yeah.
So that would make it worse. Maybe?
Yeah. So I would say even so between like the heel slams and that, still need a progression to that. So let's see, like something I would recommend. So if like heel slams are feeling really great, and even like when you slam your heels down, pelvic floor is responding well, no symptoms, I would progress to something like jumping lunges. So just like without jumping off of anything, right? So like doing a lunge and then jumping up and then coming back down and then switching, right? Okay. And then, or even like squat jumps. So like squatting and then jumping up and coming back down. Let's see how your pelvic floor responds to that. If that feels all like said and done, it's like it feels really good, no symptoms, no leakage, no nothing, then we can progress to like doing like, let's try to do 3 in a row and see how you respond to that, right? And then maybe doing something like the box jumps or jumping onto something. The different levels can help challenge the pelvic floor a little bit better. And then say like you do all these exercises and a woman's like, okay, like I feel really good, I'm not having any symptoms. And then you want to get back into running, even then I wouldn't say don't go run 6 miles now. Try to run for 30 seconds, see how you feel, take a 60-second break, and then do another 30 seconds. So do that 30, 60, 30, 60, 30, 60 for 1 full mile. I would even say half a mile. Start with half a mile first, and then progress to 1 mile, and then progress your way all the way up to 6 miles. So even between all of that, like there still needs to be like little progressions all the way up.
Progressive overload all the way through.
Yep, all the way through, yeah.
Wow, that's really cool.
Because I think most of the time what happens is women give birth and then they don't do anything for 6 weeks. And then they go to their OB 6 weeks postpartum and they're like, okay, you're cleared for all activity. And then they go running. And it's like, in what? Like, no. I actually have a coworker, one of my old coworkers did that. She had a C-section and then she was a big runner. And like, I get it though, because like if you're
craving it.
Yeah, they're craving it. And so they're just like, I really want to get back into it. So the second their OB tells them you're cleared for activity, all activity, then you go and run like 5 miles. And then she ended up having a diastasis and a prolapse.
Oh, no.
So this is where the importance of like progressive overload and progressing your way back into activity is so important. Wow. I would say like pelvic floor therapy is beneficial the day you give birth, starting with like gentle breath work, just like laying on your back and breathing, getting that coordination of your diaphragm and your pelvic floor again is going to be so essential. So that your pelvic floor can respond well when you're postpartum, like 6 to 12 weeks postpartum.
Wow.
Yeah.
If I have a weak pelvic floor, could I have a vaginal prolapse? Mm-hmm. That's wild.
You can, but I would say most of the time it's not necessarily like a weak pelvic floor thing. It's, again, like the strength and the coordination and the endurance of the pelvic floor altogether. So oftentimes people like, well...
It's always all three that work together.
It's always all three, yeah. Okay. It's... So say somebody, like, so typically what I hear, like with my clients that are dealing with prolapse, they're like, okay, well now I don't want to make it worse, so I'm going to stop doing exercise. I'm going to stop doing anything. So then you're just making your pelvic floor even weaker and you're worsening your prolapse, you know? And since we're on the topic of prolapse, there's so many different types of prolapse too. Like Your bladder could be caving into your wall. It could be your uterus caving into your vaginal opening. It could be your rectum. And I think a lot of like, this is where I kind of have my issues with the physicians in the world, is a lot of times like they just think like surgery is the only option. And it's like, educate the woman on what the options are. If she wants conservative management, refer to pelvic floor therapy or have her seek it out herself. Know that that doesn't have to be an end all be all. Like, and even if she does decide to do surgery, there is research showing the benefits of pelvic floor therapy, both pre and post-op, to decrease the risk of reprolapsing. So just educating women on like how to properly brace their core and pelvic floor, not to bear down through their pelvic floor when they're doing certain activities. All of that is going to be so beneficial so that they don't have another prolapse. So like, I don't know what the percentage is with like reprolapsing, but like say it's like, I don't know, 50%. Like say a woman gets like she has a prolapse after birth and she gets surgery. Say that, I don't know if this is true, but say that number is like 50%. Research shows that like 75% of the time, if they got pelvic floor therapy before, it substantially decreases the risk of them needing a subsequent surgery, you know? So, and also you can have a prolapse and still just live with it. Like if it's not affecting your quality of life, you don't have to get surgery. There are different like tools and stuff that I usually educate women on how to use so that they can enhance their overall quality of life.
I didn't know that there was tools for prolapses.
Yeah, so an example is, so one type of prolapse you can have is a rectocele. So that's when your rectum is kind of caving into your vaginal wall, right? And so women will typically report feeling a lot of heaviness through their pelvic floor. Like I feel like there's a tampon in my vaginal opening. That's a sign of a prolapse. So in this case, since we're talking about a rectocele, that's when the rectum is kind of pushing into the vaginal opening. So there's something called a femes, which is like it's a silicone like device. It's not a toy. It looks like a toy, but it's not. It's a tool that you basically like stick up the vaginal opening and then you kind of push against the rectum so the rectum kind of falls back into place while you're having bowel movements, and then you take it out and that's it. So you only use it when you're having bowel movements. So again, this is like another case in point of like, you don't have to get surgery if you don't want to. Like if you want conservative management, you totally can.
There's so many options out there that
I
didn't even know existed. I didn't know that was a tool that even existed.
Yeah. I mean, some people just use their finger, but I think sometimes people prefer having the device, so they don't have to use the glove and put a finger. So there are options. Yeah, and surgery is not the only answer.
I forget the saying, but like you have a patient that comes in with a headache. The ortho sees a fractured skull. The internal medicine sees whatever, and then the pain management doctor sees a prescription for an opioid, right? So like everybody gets so niched down into their thing that whenever somebody does come in with a problem, they don't think about the other thing. They only think like, well, we got to cut, or we have to prescribe, or we have to do internal test, like whatever it is, rather than like, okay, taking a step back and saying, what does the patient want? What does they say? Because they're going to lead you ultimately to your answer. I want surgery. Okay, great. Or hey, I don't want. Now as a physician, my job is to understand medicine and like know where to refer out. And so I think it's unfortunate that surgeons like to cut, man. Yeah. It's their job. I get it. I mean,
that's how they make their money. So not all of them are bad. But
so what is a misconception that people have about pelvic floors that you would like to educate people on outside of the Kegels? Because that's one that I didn't even know.
I was gonna say that's probably the most common one. Another one I guess that we kind of already touched on was that leaking is normal. It's not normal. Normal doesn't mean that you have to deal with it. So just because it's normal just because it's common doesn't mean it's normal. So that's a big misconception. I would say that and the Kegeling thing are like the top 1 and 2.
Perfect. We've talked a lot about women.
Yes. Yeah.
Do men have pelvic floor dysfunctions too? And if so, do you typically say the same 3, or like do you typically see the same issues in both men and women?
Yeah, good question. So anyone with a pelvis has a pelvic floor, right? So they're just the set of muscles that sit at the bottom of our pelvis. So men have them, women have them, children have them. So I actually work with both women and kids. I don't work with men myself, but yes, men also can be dealing with the same things. Incontinence, bowel problems, prostate issues are another really big thing with the men's pelvic floor space. So yeah, Yeah, men can also absolutely deal with pelvic floor issues. Prolapse too, but you don't have a vaginal opening, so you don't have the same symptoms as women do. So you could still very well have a prolapse, but there's no middle hole, if that makes sense.
I've seen a prolapse, and it is the wildest thing in the world.
Oh, yeah.
I was just like, this isn't okay. Like, this is kind of like somebody needs to go to a doctor. Like, this is crazy.
We need to get that checked.
Yeah. I mean, I've seen some wild videos of people with like, just like, it's like just their rectums hanging out. Like, it's crazy. Like, how that's not normal. Why does that, is that weakness? Is that the same thing? Weakness, coordination, and endurance.
Yeah. And sometimes like the ligaments are just not holding certain things up anymore. So like that's why like the rectum can kind of like slip through. But again, it's not necessarily something you have to get surgically fixed if it's not affecting your quality of life. If somebody's like dealing with that and they're like, okay, well, it's just something I'm okay with living with, like that's totally an option too. There's also different grades to a prolapse. So there's 1 through 4. So sometimes you can have a prolapse, but it stays in your vaginal like opening. It's not really coming out. So 3 and 4 are more severe, which would probably constitute more of like a surgery. But if it's just 1 or 2, it's definitely just something you can like deal with if it's not bothering you. But yeah, like it is, yeah.
So
like,
I've seen the videos of the 3 and 4s.
Like yes, the 3 and 4. Those are like severe. Yeah.
It's wild. I mean,
it is crazy.
Just to see tissue outside of somebody's body is always interesting.
Right.
But like the fact that it's so red and like smooth and just it's just a like that's inside of all of us. It's so weird, you know. It's just weird.
Yeah. I do have to say though, like so when something's like when it's a prolapse, typically it's caving into your vaginal wall, and then the vaginal wall is like coming through. So does that make sense? So that's why it's your vaginal wall with the rectum like coming through it that you're seeing, not necessarily the rectum itself, because like it's caving through your vaginal walls, and then like so it's never like there's never like a hole. Like I wouldn't say never, but usually it's not like a hole in your vaginal opening where the rectum's like coming through. You know what I mean?
Yeah. I mean, I would imagine that's very rare if that were to happen.
And that's a serious complication that would constitute surgery.
That's a big like septic issue. Like that's a big not okay thing.
I
have some other questions.
Yes.
How long does it really take to bounce back after pregnancy?
Okay, good question. So I'm not going to say like a specific number because everyone's timeline is different, right? I would say more so like whenever your pelvic floor and your core, like you feel like there are no symptoms going on, is probably when you've like bounced back. That could look different for everyone. I would say generally speaking though, it's like closer to that 12-week mark. Because like even after 6 weeks postpartum, I would say your first like 4 to 6 weeks back at the gym should still be pretty easy. And so that's why I usually say like maybe around that 10 to like 12-week mark is when you're like fully healed. But even then, like if you are somebody that engages in high impact activity like running, jumping, or even any sort of like heavy lifting, that might take a little bit longer. But again, everyone's different. Like somebody could be like 6 weeks postpartum, but if they were like an Olympic level athlete, they might be like perfectly fine again at 6 weeks, you know? So everyone's a little bit different.
That's fair.
Yeah.
Does a C-section mean that you don't need pelvic floor therapy?
No, that's another big misconception. No. So there's actually research that shows if you had a C-section, you're actually more likely to have pain with intercourse. So just because you didn't push out a baby doesn't mean you got out of pelvic floor dysfunction. And another thing people don't realize is a C-section is a major abdominal surgery. So it's the most common like surgery that's performed in America, but it's not like just a C-section. You know what I mean? Like we know a lot of people that have had C-sections, but that doesn't necessarily mean that it's just like a whatever surgery. You know, it's a major abdominal surgery. They cut through 7 to 9 layers of stuff, muscle, tissue, fascia, to get to the baby. And then once baby is out, then you're stitched all back together. And there's a lot of scar tissue that builds up underneath all of that. So even though your incision is like 3 to 4, or your scar is 3 to 4 inches wide, a lot of scar tissue underneath. So I would say a C-section mom would benefit more from pelvic floor therapy than a vaginal birth mom.
How cool.
Yeah.
I don't know if this might be a stupid question, but like
no stupid questions.
If I am at home and I have my jade gua sha thing that I use on my face,
and
I'm hearing this, can I use my jade fascia or my gua sha thing on that scar to help break up that tissue?
So yes and no. So it depends on like when. Obviously, you don't want to do anything when like you've just been stitched open. You want to get clearance from your doctor. And then, so first too, like the scar can be really sensitive, like any other scar in your body, right? So usually what I go over with clients is desensitization techniques first. So kind of like rubbing the scar with something really soft like silk, cotton, and then working your way up to like something like Velcro. If all of that feels fine, around the scar and on top of the scar, and all of that feels fine and normal, then I would say, yeah, now you can start with like topical stuff. But I would say start with your fingers first, see if that feels tolerable, and then you can work your way up into something like a gua sha type thing. Yeah.
Do you guys do Graston on those things? Is that a thing?
No. I just think it's too much.
It's aggressive.
It's aggressive, yeah. I prefer just using my fingers. I do cupping. I cup on the scar to kind of break up the adhesions and everything. Dry needling is another option. PTs can do that. As an OT in Nevada, I'm not allowed to, which is really dumb in my opinion.
Really?
Yeah. Like if I was an OT in Ohio or I think North Carolina, or like there's a bunch of different states where I can, but in the state of Nevada I can't. So even if I wanted to pursue, like get a certification in dry needling for scars, I wouldn't be able to because I
didn't know
legally
dry needling.
Can't.
That's weird. That's wild. I didn't know that dry needling for scars was even a thing. To be honest with you, I get dry needling done like medial border of my scap, and that's
really?
and then under under my armpit and stuff like that.
Okay.
And so but that's like for muscle, that's tissue stuff, not scar stuff. How does it help with scar stuff?
It kind of helps break apart the adhesions basically. So if your scar is like say like on this table, it's like this, you would do the dry needles at an angle because you want to kind of like directly go underneath the scars to get the adhesions right underneath the scar. Does that make sense? So you're not necessarily hitting muscle, you're hitting the scar to kind of like break apart the adhesions because underneath. So again, even though the scar is like just this wide, a lot of clients will say like, oh, it's only this much, it's not that bad. So there's a lot of adhesions underneath. So going in at an angle and breaking up the scar that way can really help.
How cool.
Yeah.
This one doesn't. So we had another episode several episodes ago. We talked about endometriosis, and so I'm interested just because I had no idea anything about endometriosis until that conversation, and then I learned that it's a wild thing. Yeah. So what's the relationship between endometriosis and pelvic floor, if any at all?
Yeah, great question. So endometriosis is like it's such a shitty disease. Like, excuse my language, it really is. Like. It's like a cancer. Like there's 4 different stages, right? And it can also infiltrate. Like I've heard of stories of like women's ovaries literally like fusing together because of the endo. The endo can also stick on bowels. It could be one of the reasons why somebody has inconsistent bowel movements, constipation, diarrhea. Like it could present as IBS symptoms. And so it takes on average 4 to 11 years for a woman to get diagnosed with endo just because like typically nobody knows what's going on. And then like we can tie back into like that whole concept of like, women's symptoms kind of like being dismissed or like it being like a badge of honor that a woman's like wearing, right? Like, but those symptoms are not like it's a sign that something's going wrong with your body. And oftentimes women don't get diagnosed until they notice they're having trouble with fertility. Like they've been trying for 2 years and nothing's happening. They're healthy otherwise. And the only way somebody can officially get diagnosed, like the gold standard is a surgery, getting an XLAP done. And so that's where they can find the endo. If they see any of it, they can remove it. Sometimes it could present as like a cyst, like an endo, like cyst, like on your cervix, and that's like preventing somebody from getting pregnant. It could be like blocking one of the fallopian tubes, whatever that may be. So with endo, when it comes to the pelvic floor, oftentimes it could be one of the reasons why somebody's dealing with a lot of like pelvic floor tension and tightness. So one of the things I go over are like stretches, mobility work, breath work to kind of help alleviate the tension in the pelvic floor. We also play a role in pre and post surgery. So just educating women on what to expect during the surgery. So I don't know if you know this, but during the surgery, and again, the gold standard for even diagnosing endo is a surgery, right? So before going into surgery, just educating the woman on what to expect. So I don't know if you know this, but they pump up your abdomen with CO2. And so your diaphragm is stuck in a position for 2 to 4 hours. So you can imagine if any other muscle in your body was stretched and held in that position for 2 to 4 hours, what your body's going to feel like afterwards, right? So just educating women on that kind of stuff. they just feel a little bit more empowered and have a better understanding of what they're going to do during the surgery. And then post-op, I would treat it like almost like a C-section, right? Like now you have scars, so you want to address the scars, go over some breath work, because again, your diaphragm has been stretched significantly, and tying down like the coordination again with your diaphragm and your pelvic floor, because that whole thing could have been a little messed up after surgery. Again, so if you think of like any other muscle that was stretched for 2 to 4 hours, you would need a little bit of rehab to get the coordination of everything down. So
just a little bit.
Yeah. I know endo sucks. Like I really like, my heart goes out to the endo warriors out there.
I had no idea, and unfortunately, like this specific individual that came on, Jessica Wise is her name, and I forgot what episode number she's on, but you guys can go watch that episode. She ended up getting her hysterectomy.
Yeah, I know, it's a mouthful.
Yeah, apparently right now it is a hysterectomy, and unfortunately still had a lot of symptoms afterwards. And so I can't imagine. The wildest part, and I didn't know that this was a thing, she had to ask her husband for approval to get a hysterectomy, because apparently that's a thing. Like you need both individuals to sign off.
I didn't know that.
I didn't know that either.
I did not know that. Wow.
It's pretty wild.
Yeah. What?
Yeah. Because in case she wants to have kids. In case she wants to have kids.
Oh my gosh.
Isn't that crazy?
That's insane.
Yeah.
That whole thing, it honestly, it kind of makes me mad, because it's like, I just feel like a doctor should not be saying like, oh, if we want to make sure that you don't want to have kids, and so that's why we want to make sure we perform this surgery. But if you compare that to like marriage, are you asking women and men like the same issue? Like, because there's a 50% divorce rate in this country, right? Like, are you going to ask, would it be right for anybody to ask, like, are you sure you want to get married? Because there's a 50% divorce rate. Like, are you sure you want to marry him? You know what I mean? Like, you make decisions based on what you think is right in that moment. I just think like doctors stepping in and trying to do that, it's just absurd. It's like, it's kind of dumb in my opinion. Yeah,
a little bit.
But I mean, whatever.
What do we know?
I know. What do I
know? All right. So let's see. We have a couple more questions, then we're going to call it a day, because I think we're already at an hour.
Yeah.
So what is the difference between, in relationship to intimacy, what is the difference between a weak pelvic floor and an overly tight one?
Okay, so a lot of similarities, because a tight muscle is almost always a weak muscle. So meaning, like a weak muscle typically can't even contract, right? But if your muscle is also just really tight, you're also not able to contract. But you're also not able, a tight muscle is also not able to lengthen and relax and then contract from there. So when it comes to pain with intercourse, so your pelvic floor muscles, when you engage in intercourse, they need to like be able to contract and relax, like simultaneously through the whole process, right? So if you have a weak pelvic floor, it's not doing that. If you have tight muscles, you're probably having pain at entry or with deep penetration, either or maybe even both. And so your muscles aren't able to do the same thing that they're supposed to when they're engaging in sex. Yeah.
Perfect. And then I already asked all the other ones, so they kind of came up organically. So I'm not gonna ask all of those. Yeah. So where can people find you?
Okay, well, I see clients in person at Bhakta Basics Pelvic Health. So I have my own little office space that I rent out in Henderson. But I also do a lot of virtual stuff. So I do virtual sessions. I work with women and children. So kids also, they deal with bedwetting, chronic constipation. So I also work with kids there, anyone ages 4 and up. And then women of all ages throughout lifetime. Most of my clients, I will say, are pregnant and postpartum. And then I also have something called a core rehab challenge, where I help postpartum moms rehab their core and pelvic floor, all virtually in a group setting. After becoming a mom myself, I realized how difficult it was to do that. I'm a pelvic floor specialist myself, so I was able to rehab my core and pelvic floor, myself. But when I was doing home visits, when I started my business, I realized a lot of moms knew they needed help, but they had a hard time actually getting the help that they needed. So that's why I created this online community called the Core Rehab Challenge. So postpartum moms can rehab their core and pelvic floor online in a group setting. I do group calls once a week there. So yeah.
Cool.
So virtually and in person.
Perfect.
Yeah.
We'll put some links in the bio or in the description. And then what is your Instagram?
It's tinabhakta.pft.
Can you spell your last name?
Yeah, BHAKTA.
Beautiful.
Yeah. The
awesome.
H is silent. I know that confuses people.
Yeah. Thank you so much. This was awesome.
This was great. Great conversation.
I learned a lot.
Thank you for having me.
Yeah, of course. Yeah. We'll let you know when it's out. Thank you guys, everybody, for tuning in. Share it with your friends, family, people that also might be having some pelvic floor issues. Thank you, Miss Tina. We'll see you next time.
Thank you.
All right. Love y'all. Bye.